Hello and welcome everyone. Thank you for being part of today's webinar, Building Inclusive Digital Health Together, Principles, Tools, and Examples for Equitable and Inclusive Digital Health Co-Design. I'm Jessie Checkley, a Senior Program Lead with Health Innovations Programs at Healthcare Excellence Canada. My preferred pronouns are she and her, and I am joining you today from my home office on the unceded and unsurrendered territory of the Anishinaabe Algonquin people, known as Audawa or Ottawa, territory upon which I not only have the privilege to live, work, and play, but the fall colors are showing their best. I'm so happy to be your host today. We have great presentations and activities coming up, but before we jump in, we have a few housekeeping items. Please be aware that this session is being recorded, and the recording, along with the slides, will be accessible after the event on our public-facing website. Feel free to keep your cameras off if you'd rather not appear in the session recording. To help us identify you throughout the webinar, please confirm that you are named correctly in the participant list. To do that, open your participant list from your Zoom toolbar at the bottom of your screen, hover over your name, and if you need to rename yourself, simply click on Rename and then click OK. We are delighted to provide simultaneous interpretation services for this session. To access the voice of our interpreters, kindly choose either the French or English from the interpretation menu located at the bottom of your screen. Your comfort and understanding are our priorities, and we want to ensure that everyone can fully engage with the content. If you have any difficulties connecting to the language services during today's session or any other technical difficulties, we ask that you contact Sasha Nealon via private message or through her email, which can be found in the chat. At Healthcare Excellence Canada, we recognize that we are still learning how to respectfully support reconciliation efforts and develop meaningful relationships and partnerships with First Nations, Inuit and Métis governments, organizations, and communities. As part of this journey, we strive to support cultural safety and humility in the healthcare system and to enhance the capacity of the healthcare system to meet the needs of First Nations, Inuit, and Métis. Healthcare Excellence Canada honors the traditional territories upon which our staff and partners live, work, and play. We recognize that the standard of living that we enjoy today is the result of stewardship and sacrifices of the original inhabitants of these territories. We commit to not repeating past mistakes and to working towards more equitable and respectful relationships with First Nations, Inuit, and Métis peoples. Please introduce yourself in the chat and share the territory where you are joining us from. If you're unfamiliar with the territory you are on and the history that has built and preceded it, we've shared a link to a great resource, Native Land Digital, in the chat. We are delighted to welcome an esteemed panel of speakers who will be leading the presentation and activities today. Dr. Paula Voorhees is a postdoctoral researcher at the Science of Care Institute at Sinai Health. She's pardon me. I'm really working quickly today. She's a MyTax Elevate Award recipient and works as a lead of research and development at VeroSource Solutions, Inc. Dr. Voorhees' topic of expertise is in behavioral science, design thinking, and collaborative design. Her current work focuses on using design thinking and behavioral insights to evaluate and improve personal health records applications across Canada. Ron Boleno advocates for dementia, caregiving, aging, and research communities. Ron was a caregiver to his father, who lived with Alzheimer's for 10 years. He's a patient perspective keynote at the Technologies in Emergency Care Tech 2023 conference. This was followed by Ron being a co-author as a patient partner on the published paper, Essential Digital Health for the Underserved, Consolidating Principles for Equitable and Inclusive Digital Health and Virtual Care Co-Design. Ron is also the co-chair of AgeWell's Older Adults and Caregiver Advisory Committee and received their Honorary Fellows Award for 2020. He is an advisor, presenter, and coach for numerous groups across Canada, such as CIHR's Institute of Aging, Healthcare Excellence Canada, and the Canadian Centre for Caregiving Excellence. Dr. Carolyn Steele-Gray holds a Tier 2 Canada Research Chair in implementing digital health innovation. She's a scientist at the Science of Care Institute and investigator with the Lunenfeld-Tannenbaum Research Institute at Sinai Health and an associate professor at the Institute for Health Policy Management and Evaluation at U of T. Her program of work focuses on the role of digital health in supporting integrated and person-centered care delivery for patients with complex care needs, applying implementation science theory and approaches, along with evaluation methods to uncover how best to embed technology into novel delivery models. Dr. Jennifer Stinson is a senior scientist at the Child Health Evaluative Sciences Research Program within the Research Institute at the Hospital for Sick Children or Sick Kids in Toronto. She's also a nurse practitioner in the chronic pain program in the Department of Anesthesia and Pain Medicine at Sick Kids, and a professor in the Lawrence S. Bloomberg Faculty of Nursing, Department of Pediatric Anesthesia and Pain Medicine, and the Institute of Health Policy Management and Evaluation at U of T. She leads the iOuch Lab, which seeks to improve health outcomes in children and youth with painful chronic conditions using digital health therapeutics. Our guest speakers will each lead a presentation introducing the principles, tools, and examples for equitable and inclusive digital health co-design. We'll have three major sections: pre-design, co-design, and post-design. Each section will be followed by a group activity, which will allow you to participate and engage in the discussions. We will then open the floor to our panel of speakers for some questions and answers. If you have questions or thoughts at any point during the session, please feel free to write them in the chat, and we look forward to active participation today. Without further ado, I'll now turn the presentation over to Paula.
Thanks so much, Jessie, and hi everyone. It's great to have you all here, and I'm really excited that we can share the space for the next hour and a bit. So to get started, I think it would be good to talk about what co-design even is. And so there are many definitions out there, but at its core, co-design is really a collaborative process of creating a product or service with those who are intended to benefit from it or be impacted by it. And so this really means that instead of designing for people, we're really designing with them, ensuring the most impacted voices are actually central to the design process. And so, although this idea is great, and I'm sure we're all on the same page on that, the reality is, as Isles and colleagues have found, that many co-design projects do not engage a diverse range of patient and care partners, especially those from equity-deserving groups. And so this means that some of the most prominent voices who are most likely to need this particular service are actually left out of the conversation despite our best intentions. On the other side, thankfully, over the past several years or so, there really has been great advancements in the frameworks and principles to really guide more equitable and inclusive co-design. However, these advancements have tended to sit across different academic literatures, and that can make it challenging for us to really integrate and make sense of them in practice, and especially in a digital health context, which adds even more complexity. And so, next slide. Awesome. So basically, thankfully, over the past several years, there really has been a push to review and compare and consolidate these works in order to break down the silos between kind of experts that are working on this topic and consolidate this guidance to really make sense of it. Next slide. And so really our team has been central to this process of really delving into this literature. And we're excited today to present our work, which really did this job of kind of bringing together lots of different advancements in the field. And we have created a new tool called the Consolidated Principles for Equitable and Inclusive Digital Health and Virtual Care Co-Design. And you can see, I think there's a QR code on the screen right now, as well as a link that would have been sent in the invite that you can kind of refer to the paper throughout the chat if that's something that you're interested in. Next slide. So to give you an overview of this guide, it is really organized into 3 critical phases, which my colleagues will delve more into in a second. But essentially, to give you an overview, it starts with pre-design, and pre-design really focuses on getting ready for co-design, and this is often overlooked in the process. And pre-design really includes contextual inquiry, which is about how your user group actually navigates the world and really understanding that before you start. And then planning and preparation, which is really about meaningfully bringing together equity deserving partners to discuss the methods that actually make the most sense for that group in co-design. And then the next section is to move on to co-design itself, which is actually about designing, in this case, the digital health innovation with your equity deserving groups. And in this bucket, it's really about how to approach the product design. So this is the design of the actual technology and its content, as well as the implementation design, which is often overlooked. And this is really about how do you involve, all these different groups of people to really best plan about how to deliver, market, and scale an innovation in practice. And then finally, the last part of this framework is really moving into post-design. And again, this is often forgotten. Often we think of co-design as just doing some workshops and then developing something and then kind of forgetting about it. But post-design is really about how we collaborate with equity deserving partners over time to make sure the innovation just doesn't fall by the wayside. And so this phase really includes first ongoing evaluations to capture meaningful data about how the innovation is actually working in practice, and then sustainability planning in order to ensure that there are champions there to make sure that there's a commitment to continuing to improve innovations over time. And so we have put together this framework, which we hope is going to be a pragmatic tool to really help everyone who is interested in co-design to actually be able to do it rigorously. Next slide. And so, yeah, so I guess at the end of the day, we've put together a list of principles from all these other colleagues who have done a great job in this literature, but it's really about committing to it. And it might seem overwhelming at first to look at all of these principles and wonder how you're going to do it. But the reality is we really can do it. And that's why my colleagues here today are going to share some stories, about challenges and benefits to approaching co-design in this way, and really give some examples so you can see how it's done in practice. So I think I'm going to hand it over to my colleague Ron, who's going to talk about his personal experience with pre-design and some lessons learned there.
Thank you, Paula, and greetings, everyone. Pleasure to see many familiar faces and names here. So I will be talking about the pre-design phase here. Key part here is the pre, okay? Pre being the beginning, okay? As Paula said, it's about getting ready. And many times, some of the success actually happens here, so that a lot of the heavy lifting and all of those future failures won't be as big if you can be prepared earlier on. So what is pre-design in the context of designing equitable and inclusive digital health? Well, there's 2 parts. There's the contextual inquiry, and then number 2, there's the planning and preparation. So for the contextual inquiry, that's when you're beginning the process. And sometimes it's not even formal at this stage, okay? So you begin the process, and we want to learn. So it says here, deeply learning about how things are currently done. Sometimes it's just getting the pulse, okay? Sometimes it's just kind of getting the lay of the land and figuring out, well, where are we at this moment, okay? Before we start jumping and making assumptions, Sometimes it's good to make assumptions, But some of you all know when you assume, you can make an ass out of you and me, if some of you know what that is. So we want to kind of go through the contextual inquiry, which is about initiating, liaising, understanding, and structure. And for the initiation piece, for me, a lot of this has to do with, as in my space, as the patient partner, as the lived experience, kind of many times that stakeholder that you're all working for. The relationship is a big part. So developing those relationships early on, and you want to build on that capacity, one relationship at a time. Paula used the word champion. That's a big part of this. Who are the champions, or who will be the champions that you're initiating with? To liaise with the community. Sometimes you have to kind of understand that it's not just one person, it's a group that you're liaising with, that they represent a bigger community as well. You want to understand the social technological context with a focus on users' needs. That piece is kind of important, understanding their needs. Again, not just assuming what they are, but to really get that early on, to kind of ask those questions, those more powerful questions. I love questions related to emotions. That's just me personally. How do you feel about this? Okay. Structure. Does the structure an equity-driven design environment, considering policy levers and structural change? So a big part of this is, how are we putting this together, okay, so that it is equitable? Okay, are we not talking to the best people? Do we need to kind of go and find others? Okay, who do we need to talk to? Who do we need to kind of discuss this with at this stage? And then second part here is planning and preparation. So how well are you all at planning? So bringing together equity deserving partners and prepare the materials and methods you'll use. So you want to plan, invite, orient, and build. So planning, okay, so a big part sometimes is the time and the resources. I will always say, I've spent a lot of time with this community. Many times you have to plan that time, that amount of time and resource. Okay, sometimes you kind of say, well, we're going to do this in 1 hour, and then that hour's up and we barely get through all of it. So sometimes make sure you plan a little better. We want to make sure we do a good job at inviting the community over. How do we invite them? Sometimes we have to go meet them where they're at. Okay, sometimes it's not in your space, it's in their space. Orient. Okay, orient co-design partners by establishing a clear understanding of roles, expectations, and training. Okay, especially for some of the stakeholders who are the lived experience, such as myself. Many go into these initial pre-design sessions, or even throughout the whole project, not even knowing what their role is. They weren't prepared early. So onboarding people, orienting them better, and then to build an equity-driven co-design environment, considering policy levers and structural change. Okay, so next slide, please. So I'll give an example. On my end, one of the organizations that I've been supportive of and that I co-chair is AgeWell, which is Canada's Technology and Aging Network. And when they started back around 2015, it was all academics, all researchers, okay? I believe, the first lived experience caregiver to be part of AgeWell, okay? So 3 of the main groups within the AgeWell community are the researchers and academics, the innovators, and then there are the lived experience. We call it older adults and caregivers, okay? Or some will call patients in a different group, or lived experience. So within AgeWell, over the years, okay, it's become mandatory that every project now is strongly encouraged, to make sure that in the pre-design, phase, that there is either an older adult or a caregiver already discussing, with the team. It doesn't have to be formalized yet at that stage. Sometimes it's actually just sitting around a table. So that middle photo you see there, okay, is just a dinner where there's probably about maybe 10 trainees and 10 older adults and caregivers. That's something we do sometimes to say, okay, what are the projects you're all are envisioning to work on? Okay, before you go too deep into it, let's just have that conversation. And so that's what that group is right there. So that's the one in the middle photo and the one to the right. The left photo happens to be, just at one of the conferences, a picture of some of the older adults and caregivers, and you could see how serious that group is. They are quite a fun group every year. And it's about them living their lives and kind of that group trying to tell in the pre-design phase to kind of say, hey, this is what we got to focus on and be aware of as we're moving forward. Something that, hey, why are you doing it this way? Before you get 10 steps too deep into this, okay, we're already flagging you on step number 2, no, for example. So the importance in this community for the work that I do is that I've always seen how many projects pivot from the very beginning in the pre-design phase before they go too deep into this. So that is just an example of one group that I collaborate with that they've been doing it quite well for many years now. Okay, so next slide, please. Okay, so we are now going to kind of start getting into activities. There's going to be 3 of them. I will do the pre-design activity example here. I'll explain this here before we are instructed how we go into our breakout rooms. So this one's quite personal to me. Okay, so I picked one that I'm really connected to. My father, as you kind of heard earlier, was living with Alzheimer's and dementia. And this was over a decade ago. He peacefully passed away at home in 2018 after 10 years living with his dementia. And one of our challenges was keeping him safe, not just at home, but out in the community. Okay? And part of this, you got to remember, this is pre-pandemic. Okay, so many of us now, since the pandemic, will say, okay, well, there's cameras. We have people have cameras in their homes. We're doing video conferencing. So that's now. Okay, but this was before when my dad used to go missing, and this wasn't even common yet to use sensors in the home. Okay, so you and your team, okay, are considering a remote camera monitoring system to support families challenged with dementia who want to age in place in their home or in their homes. Individuals with dementia, okay, such as my dad, their family caregivers, such as myself, many who work full time. There's also first responders, and the community members are struggling to keep my dad safe at home or out in the community, especially those living with dementia and those at risk of going missing. So the questions we are going to kind of discuss when we get into our groups, how will you approach pre-designing in your community? Okay, how will this be done? And consider these 3 questions. Hopefully we can get through all 3 of them. Now, number 1, who are you specifically planning to design for? Okay, who is that you're going to be bringing to the table? And where will you find and connect with these users? Okay, so I think that's sometimes the struggle that I see this whole community will have an issue with. Sometimes you always get the same group of peoples over and over again to your projects. Okay, that's not really equitable. That's now just a relationship, which is great to get to that part. And then, so where will you find them and how will you develop relationships with these users early in design? So I'm always curious as to how creative sometimes you can be.
Awesome. Thanks so much. I'm really excited that I get to chat after having an in-depth conversation about pre-design and what it takes to find the community, the groups that we really need to connect with, and some of the challenges and opportunities in front of us to do that really well. So once we've done that, so let's say we've done our great work in identifying the people we need to connect with. We've gone over the hurdles of getting to seldom heard from communities and individuals to make sure that they're part of our process. So now what do? We need to actually create a product and likely a model of care. In the dementia example, we're perhaps developing new or adapting existing technologies and then putting them into practice. And that to do so from an equity lens and from an inclusive lens requires not just co-design, but equity-informed co-design. So in the paper, we pull from lots of literature to suggest ways that you can do those co-design activities with an equity-informed lens. And I'm sure a number of the people in my group already have done some co-design work. So I'm going to focus a little bit on kind of what it means from an equity-informed perspective, rather than kind of going from a high level overall. But to start, let's go to the next slide, please, just to kind of level set on what we mean by co-design. And this is a really nice definition that comes from the Tamarack community, from Liz Weaver and her work there from the Tamarack Institute. And what I like about this definition is it rests in recognizing that in order to co-design well, to really create something new with diverse groups and diverse perspectives, we need to really elevate power in the room. And we need to understand who holds it and who doesn't, and how that can really influence what we create at the end of the day, and how we create a space in which we're designing the product or the intervention and designing the implementation of that, like the actual putting it into practice, the model of care, the approach. How those power differentials, if they're not attended to, can steer us in directions that may not be helpful, particularly when we're talking about seldom heard from and underserved and equity deserving populations who typically don't hold as much power in a particular room. So the way we come to our co-design process needs to attend to that, and this definition helps really elevate that concept for us. And now if we go to the next slide, this is another really lovely process model that helps us understand the ways in which that we can actually engage. And I'm sure a number of you have seen this before. This kind of comes from the more patient engagement framework, but it really helps, or the patient engagement literature, but really does help us in thinking about the different ways in which we engage in co-design with a diverse user group, and particularly when we're thinking about patients and their family caregivers in our communities. And if we elevate the notion of power, and that we need to attend to that with equity deserving communities, we need to think less on the left side of this diagram, less on just learning from them, kind of drop it like we used to traditionally do, drop in, hear from people, pull their information, and off you go, but actually move toward the right side of this diagram, where we're meaningfully collaborating, and we're not, and so that we actually share power, or perhaps those who are leading or who have traditionally led step back and let the community, patients, caregivers actually take leadership and actually move forward with those who would historically be taking leadership, being more supportive of that. So again, that takes a different tone in the way that we engage and the types of activities that we would do in the co-designing of the interventions that we're doing, whether technology or otherwise, and the co-designing of our implementation. Yeah, so if we just move to the next slide, I did want to take a moment just to differentiate between co-designing a product from co-designing an implementation. And we do this in the paper as well, and kind of break down the different stages of each thing. So I'm not going to go into too much depth about those two things, because I want to get us into a little bit of an example and then get us back into the room so we can chat some more, because I think that was really engaging and fun for us to apply the learning. And then on the left side is kind of a visualization of what we mean by designing. So when you have a mobile technology, a new virtual care platform, you're actually creating the interface, perhaps, you're creating the monitoring system, you're actually going through the design process. And this is one image just shows us how messy and intense that is. But if you kind of go back to some of the foundational work by Sanders and Strappers, one of the foundational ideas there is that we need to see our kind of user groups as designers themselves, that we're not just extracting information from them and informing design, but there is design knowledge and understanding within the people we're trying to serve. And we're creating environments in which they can share and create solutions for us to think about and create and action. So that's kind of the one end of co-design, is actually creating the product or the intervention. Related to that, on the right side, is just an image of one implementation framework. I tend to like it, but it's more just for a visual, that we don't just design products, particularly in technology, we think about how technology sits in a model of care or in a service kind of line, right? We're not often just resting on the technology. There are people involved, there are different services that are involved. So it's kind of part of the delivery, the care delivery model. And what we're suggesting here is that as much as it's important to co-design and co-create an intervention itself, it's also really important to co-design and co-create how you're going to even put that intervention into place. So how will you onboard people onto your new virtual care platform? We don't necessarily want to assume that, because we talked in our group just now how not everybody has access to a particular technology. And that's going to change the way we think about implementing, say, a virtual care platform. Because if we're going to hit lots of different communities and lots of different folks, they might have different needs in terms of how they would access a particular service that was digitally enabled. And same thing for as you go through the implementation process, like how it runs over time, how you know if it's working or it's not, and even how you evaluate it at the end of the day. All of those steps of implementation, of putting something in practice and seeing if it works, that can be co-created, and it should be encouraged to be co-created with the communities that you're serving and all of those different stakeholders who are involved, the providers, the communities, perhaps even the tech partners. Everybody who has their hands in that has insights into why it's working or why it's not. And we need to think about engaging them meaningfully in each of those stages. And to the next slide, just a very quick example from something we've been doing at Sinai Health. We've been co-creating a technology to support transitions for older adults with complex care needs, going from hospital to home. Very complex group, often representing many equity deserving populations. Now this is like a 4-year project. I'm not going to go through everything, but there is a website there if you're interested in it. But I think the thing I really wanted to talk about on the next slide are the different ways that we've engaged in the co-design process through the entire program of work, but also through the development of the technology as well as the development of the implementation. So we do things like have project patient partners who are leaders and thought leaders on the project itself. They help create the idea, and they hold decision-making power within the team. We have an advisory committee that is patient and family members who we vet all of our stuff with as we go through all of our recruitment materials, all of the technologies, all of our implementations. They have a say in how we're doing those things, and we feed back to them how their reflections are changing the way we do this work. And then, of course, for the technology and the model of care and its implementation, we have co-design working groups with a lot of different folks who are involved in that. So this is just to show there are lots of different ways to do co-design, and there's lots of different ways that you can think about it in the breadth of the work that you're doing. So with that, our next activity. Let's do some co-design together. Now we have a new example for us to think about, just to shake our heads up a little bit. You and your team are hoping to co-design and implement a new hybrid, virtual and in-person program to help older adults in your community be more active. Your community is vibrant, they're diverse, lots of families who have newly immigrated to Canada, as well as families who've lived there in a long time. Lots of different languages are spoken. So in your groups, you're going to talk about how are you going to approach co-designing your new hybrid model of care? Who are you going to engage? How will you do so? And how will you attend to equity with this, with your approach?
Great. Thank you. So we've walked through the pre-design and the co-design, and now we're in the post-design. And I would argue that this phase is something that we really need to think about in the pre-design, because I think we get to the co-design and we spend a lot of money and we do research to evaluate whether it's effective. And then most of those solutions never get into the hands of the people that we're designing them for, whether that's patients or families or healthcare providers. And an example from one of my colleagues, Christine Chambers, she did a review of e-health tools in the pediatric pain space, and that's my clinical expertise. And she found that only 1/3 of them actually used the co-design, and those that actually did, they had a higher percentage of actually being implemented in everyday practice. So it speaks to the importance of this phased approach and making sure that we're really bringing in that equity lens to make sure we're really getting all of those populations that we're striving for. So in this phase, usually by this time you have a product, you might have done some evaluation of it. In building these tools, I think it's really important that we make sure we build in an evaluation component, whether that's built into the virtual solution, getting input from those that are using it in terms of how it's helping them, how it's impacting on their clinical outcomes, how it's impacting maybe on the workflow of healthcare providers. And then we have to think about the adaptation and sustainability. And again, I would argue that most people aren't thinking about this in the pre-design, and they really should be, to make sure that you really have those key partners and people that are going to champion your intervention or your solution, get it adopted into practice, and then eventually it may be obsolete over time as technology changes, but we always have to be continuously evaluating these solutions to make sure that they're meeting the needs of the population that we're targeting. So again, it's really important to identify who those champions are and continuously learn and use that data to refine your product over time. So if we can go to the next slide. I'm just going to give an example. So as I mentioned, I work with young people with chronic pain, and one of the populations that I'm really interested in is young people that have sickle cell. So this is like a genetic condition, and it primarily affects Afro-American youth. And these episodes of pain, whether it's acute or chronic, can impact all aspects of their life. And we know that this group is also facing racial and cultural inequities related to their sickle cell disease and their ethnicity. And so we've developed a product called I Can Cope. This is a digital therapeutic that's a native smartphone that is available on Android and iOS. And we really built this with co-designing it with young people. So we did what we've already talked about. We reached out to the sickle cell communities. We've reached out to healthcare providers and clinicians. We built this tool and co-designed it with young people with sickle cell. And then we went and we got funding to evaluate its impact on clinical outcomes. And in this case, it was improving pain-related outcomes. And we got funded to do a clinical trial in the United States that showed that actually youth were engaged with this program. It reduced the number of pain days that they had, and it had some impact on their mood and activity. And so we recently got funded by CIHR because now we have the evidence that it actually improves clinical outcomes. Now we're at the stage where we want to implement this in all the sickle cell clinics across Canada. So what we propose to do is do a preparation phase within this post-design where we actually prepare each of the clinical sites to find out what are the barriers at each clinical site, what are the facilitators, who are the champions that are going to advocate for prescribing this app to young people with sickle cell disease. And then we want to collect all that data, develop a plan that then will inform the implementation of this sickle cell app within the various clinics across Canada using theoretical frameworks. In this case, we're using Proctor's framework, which is there's many you can use. And then I think what's really key is that once you finish these implementation trials, this is a hybrid type 2 because we already know that we have evidence that it's effective. What we don't have evidence of is can we implement this in the real world and then look at the effectiveness as well. So once we're done with that, we actually want to meet with all the clinics again and look at what are the lessons learned, what worked, what didn't work, and then develop a roadmap where we can implement this and scale this not only in other centers in Canada, but also look at then maybe moving it to other contexts like the United States or the UK where there's different healthcare systems, et cetera. maybe we can go to the next slide. So let's work on an activity. So your team is going to implement the I Can Cope within the sickle cell communities across Canada. Think about how you would co-design some of the implementation strategies. I talked about some of them, but who's it key that we engage? How will you engage them? And when? Is it at one time? Is it multiple times? How can you assess their readiness to implement something? Are there tools you can use? How can you tailor the strategies to each individual site? And then what would be some of the things that you would have as metrics for success in terms of scaling this up across the sickle cell sites?
Yeah, I just want to thank everyone who participated in the breakout groups. We're obviously all of us who have spoken today are open for conversations after this. You have our contact, our names, our emails. We've had some really great conversations, and I really appreciate that. So maybe for the next 5 or 10 minutes or so, I've collated a lot of different comments and questions that everyone has asked in the chat as well as in the breakout rooms. And I think it might be good to address some of these. And so, yeah, I think maybe I will actually ask the questions to the leads who talked about these might be a good way to do it because I think some of them are for specific people. So maybe Carolyn first, I want to ask you a question that was talked about, which is really about how we help people or groups become designers themselves. And I know you talked about power, and specifically in the case of digital health, where a lot of people might feel uncomfortable talking about designing digital health solutions, but they might feel comfortable talking about their experiences. So how do you navigate helping people feel like designers or giving them power in this specific context?
That's such a great question, and I think an ongoing challenge. I might reflect a little on what my breakout group talked about in our 3 sessions to kind of respond, because I think the thing that kind of came out quite a bit was the need for kind of relationships and trust and creating kind of a space in which people feel like they're being heard. And I heard the term being met where they're at. And I think that that is also foundational to folks feeling like they can also be designers. Because if you come to them and say, we're designing a tool, and they don't feel like that's an identity they hold, the response is, well, I'm not a designer, or I'm not a techie, and we hear that over and over again. So I think reframing it in a way that makes sense to who they are and what their identity is, and sharing that that is hugely valuable to our understanding of how to solve a problem that's meaningful to them. It kind of makes it connected to who they see themselves in their role, as opposed to placing a label on them about, you be a designer now. If they don't identify that way, it's not going to make sense. But if you say, you be you right now, and you tell me what's challenging, and like, let's think through how we might solve that, it's a different kind of procedural conversation, but it does require relationship building, trust, and power seeding to make that work really well.
Awesome. And then just a follow-up question for you, Carolyn, before I move on, is, in your example, you talked about, how to maybe engage a community where people are struggling with maybe, helping older adults become active. And it's really broad. And we talked in our breakout group about not boiling the ocean. So, in the sense of, when do we want to try to, be broad and try to make a solution for everyone versus when should we actually focus in on specific equity deserving groups, and how do we balance the need to do kind of both of those at the same time if we feel that tension?
I actually think that's one all of us can answer, right? And it's kind of an ethics kind of question. We use our resources to benefit the folks we're trying to benefit. And so we will internally go through prioritization exercises and come back to people like, we're going to design or build something and co-create it to the best of our ability for everybody, but we know we won't make it make sense to every single person. But we tend to prioritize kind of the patient journey and the patient challenges. but I think it's an ongoing challenge. And I'm so curious about how Jen might answer that question.
Thanks. I totally agree. I think it's quite tricky, and as us as researchers, we usually try to apply, for a set of funding. And I think in our lab we do something very similar. I think before we even think about doing a virtual or digital solution, we meet with the people that we're trying to design this for and really work with them to say, is this even the right solution? So taking a step back and not going in with a preconceived notion of, is a virtual solution the best solution for the population? And then in our co-design, we work with the human factors group at University Health Network, and we really spend a lot of time sort of getting to what you were talking about co-designing and really getting them to prioritize what are the most important features. And we also, for each thing, come up, what are the underlying principles that we're trying to address in this solution? So for the I Can Cope app, it was like, keep it simple. It's not just about my pain, it's about my life. And I want a safe space to be able to relate to other people. So those are the guiding principles that the young people talk to us about. And we kept those four in front of everything that we did. And then there were certain things that were nice to have that, sure, if we get for their money, we'll put them on our roadmap to include them. But we start off with what's most important that the patients or the people that we're working with prioritize.
That's an awesome comment. I love that example too. And maybe Jen, I'll ask you another question that came up in our breakout group. And in terms of evaluation and how maybe in your example, you've tried to understand not only the users and maybe, user usability evaluation and what features they like and that type of thing, but how you capture, the people who didn't know about it in the first place, the people who knew about it and decided not to use it, and the people who maybe started using but then fall off from using it. And how do you engage, I guess, all these different groups in a post, I guess, implementation evaluation when you're trying to basically use those lessons learned moving forward?
Yeah, so again, it's coming back to just figuring out and really clearly articulating the groups that you want to focus on. So one group is obviously, we want the clinicians to prescribe this to all the young people that are experiencing pain that need it. And so we put in mechanisms within the workflow to sort of say, how many people did they actually pass this on to in the aftercare summary, right? So there's different ways they can prescribe this to patients. So there's metrics within the workflow of the healthcare provider, but we can also track like the number of patients that come to the clinic, how many were prescribed it, and then we have data within the app itself that collects data on what they're engaging in within the app. So I think it's really important to map out all the data points that you could possibly get, and then what are the best. And this came up in our group as well as a comment, is the data that you need is almost like the data that you need if to convince, if it's like in Ontario, I want the Ontario government to pay for this app to be integrated into clinical care. I need to involve those decision makers in that, in terms of what's the data they need to be able to support that adoption of this virtual care solution that you're building. So it depends on the different stakeholders. But those are conversations that you should have almost at the pre-design as well, in terms of what data is most important to each target audience, is how I would look at it.
Yeah, and that's a great transition, I think, back to you, Ron, about pre-design and maybe making those connections to understand like what success means for the people who you're designing for. And I don't know if you've had any, in your breakouts conversations about, being clear about how to really establish those connections to understand really what the problem is and what success looks like before even getting into any of the nitty-gritty of the design.
Yeah, our breakout group here actually, as we kept going through our different examples, kept growing back and forth at the different design, stages, right? Especially for the last one with Jennifer's example, right? It brought us back to the pre-design conversation as well. To succeed well in the post-design, okay, you would have had to kind of plan it out maybe even earlier in the pre-design. So a good example would be simply the knowledge mobilization piece, okay, the knowledge translation at that post line. Like, how do they even know about, how does the community know about this? Well, you would have had to kind of plan that out and not just wait at the very end when maybe the budget and the resources are already gone, and you don't have time anymore to develop the relationship with the community and the key stakeholders. So part of that also in this is also knowing the language of the different stakeholders. Okay. So a good example could have been maybe a survey is the word that's being used, from your side. From my side, it's like, oh, some questions, surveys might be too official for us. Okay. So a lot of this now comes back to the constant communication with the stakeholders throughout, especially not just saving it until the very end. And that should be planning in the pre-design to kind of say, yes, we even have our stakeholders, maybe we don't need them now, maybe we're going to need the stakeholder at that time, but let's not wait and communicate with them at the very end. So that was a big piece. Yeah.
Yeah, I love that. Yeah, I think Jen commented in the chat too. That's a really great point. And then maybe one more question for you, Ron, that kind of came up with us, and something I think we've all been thinking about is someone was commenting about how to prioritize connection before content. I think that came up in the chat as well, and how to do that. Like, how, if you were new to the space and you're really wanting to establish those relationships in pre-design and really dedicate that time, do you have any kind of reflections on the best way to really prioritize connection over content when you're starting?
So this is my personal space of what I'm thinking. This is Ron's thoughts on this, is get really better at the questions. Okay. Have more impactful questions. No questions that will really hopefully jump the work forward. For me, in my space, that is getting to the emotional question after connecting with something. So how the heck do you feel about this? Okay. And then reverse engineer and say, well, I don't trust this. Okay. Oh, what is it that you don't trust? That's how I've done it. Okay. That's again, my personal opinion is if you can get to those emotional questions along the way. I know there's all this data we collect and all that, but if you get to that emotional question and then reverse engineer, oh, you thought it was great. How did we get to great? Kind of thing. So that's just my personal opinion of one way of doing that there. And yeah, just knowing how to ask better questions.
I love that. And that kind of takes us back right to the beginning of starting with a curiosity mindset, right? Co-design is really about curiosity and trying to really understand people and problems and opportunities. So I know we only have 2 minutes left. So thank you, everyone, Carolyn, Ron, Jen, for your contributions. And I'll hand it back to Jesse, who's going to wrap up the session.
Thanks so much, Paula. So let me start by saying first, we'd love your feedback on today's session. We use feedback to make improvements to programming and to support learning. So please let us know how we're doing by responding to the poll you see on your screen. I also would like to extend a huge thank you to our speakers, Paula, Ron, Carolyn, and Jennifer. Thank you for sharing your work, your experiences, and your expertise with us today. I'd also like to thank our interpreters and production team working behind the scenes to make this session possible, as well as to all of you for joining us today and taking the time in your day to do that. If you have any questions or comments, please don't hesitate to reach out to us using the virtual care mailbox shown on screen. If you're interested in learning more about HEC or partnering on Appropriate Virtual Care Collaborative, please visit the website or the link we shared in the chat. And just to let you know that this concludes today's session, and we look forward to seeing you the next time. Thanks to everyone for such a great conversation, and we'll send out more information following the session.